The video series Better Disease Management was developed by the Georgia and Oklahoma Academies of Family Physicians as a part of the Go Diabetes Initiative. The Better Disease Management series consists of 7 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
Case study 2. 32-year-old Caucasian female with a history of gestational diabetes. All right, presents for confirmation of pregnancy. So she's in your clinic, doctor, I'm pregnant. Recent home pregnancy test was positive. She's having no symptoms except she gets up at night to urinate. She's got nocturia, no dysuria, and she has no fatigue. All right, past medical history. She's got 2 kids, ages 3 and 26 months. Previous gestational diabetes requiring insulin therapy during both previous pregnancies. Her glucose tolerance test 6 weeks postpartum was normal. Family history, there's no diabetes or no vascular disease. So that's interesting to plug that into your mind as you think about this patient. All right, she doesn't smoke, she doesn't drink alcohol, she walks 30 minutes, 5 to 7 days a week. This is the kind of patient you like. I mean, this is like, they're doing what she's supposed to. Her weight's been stable for the past 4 years and she eats well. Her exam, she is 5 foot 4 inches and she weighs 110 pounds. Wow, that's interesting. Blood pressure, she's normotensive and the rest of her exam is normal. Her labs, her pregnancy test is positive. Her A1C is 9.4. Her glucoses, 3 hours after eating, 277, okay? And then yesterday at her primary care physician's office, it was 295, and that had been about 4 hours after eating. So, questions, is she diabetic? And is she type 1 or is she type 2? Oops, that one didn't have the ability to answer. Raise your hands. Type 1? It's okay. Type 2? Okay. She's a type 1. This is a confusing one. This is meant to trick you, so don't feel badly if you got it wrong. But the key things here, look at her weight, okay? Look how bad her hyperglycemia is, okay? Her blood sugar's 277, 3 hours after eating, A1C of 9.4. She is catabolic. She has nocturia, so she's going to be losing weight very soon if she's not already. She's normotensive, normal BMI, and she walks 5 to 7 days a week. How many type 2s do you know that look like that? Don't know any. So this is an unusual case, but the teaching point here is that keep your antennas up. Some type 1s will present in pregnancy. Okay, that'll be the first time they really had much health care. And so if you see a thin type 1 who's had gestational diabetes, then just keep that in mind that that's a possibility. All right, next case. 78-year-old nursing home resident presents for evaluation of recurrent episodes of severe hypoglycemia. Diabetes was diagnosed at age 65 during a routine insurance exam. Okay, and I'll give a little disclaimer, I'm not advocating this insulin regimen, but current treatment includes insulin 70/30, 14 units in the morning, glargine insulin, which is Lantus, 10 units at bedtime, and then they throw in a sulfonylurea just for kicks. Blood sugars have been from the from the 30s to the mid 500s for the past 2 weeks, and that's why she's there to see you, is because of these crazy blood sugars. The average measurement when you look at the glucometer is 196. Past medical history, none. Family history, there's no history of vascular disease in her family. Doesn't smoke or drink alcohol. Physical exam, 5'1", blood pressure's normal or high normal. Weight, she weighs 98 pounds. Further exams normal. Here's the labs. A1C is 8.6. Creatinine's 1.3, which may be technically normal, although we would know in an elderly, thin woman that's high. I mean, that's actually higher, and she doesn't have normal creatinine clearance. Look at her lipid profile. Her total cholesterol is 150, HDL is 70, LDL is 70, and triglycerides are normal. So, diabetic, type 1 or type 2? I don't think we get to answer. Do you remember, Sue, did we get an answer if they're type 1 or type 2 on this one? All right. Yeah, so that one's pretty easy. 92%. All right, who answered no? All right. No, type, A1C in the 8s, that's diabetes, okay? The question, is she type 1 or type 2? Key thing, she weighs 100 pounds. She's got normal lipids. Do you know any type 2 diabetics that are 100 pounds and have an HDL of 70? I mean, I don't think I've ever seen anybody that has one like that. And notice how variable her blood sugars are. She is not, the reason why you have less blood sugar lability in type 2s is because of insulin resistance. If a type 2 gets too much insulin, they're kind of like, If a type 1 gets too much insulin, so you'll see the 30s and the 500s. So you'll see these big variations in type 2, in type 1 rather. Okay. Case study 4. "32-year-old African-American male presents for evaluation of poorly controlled diabetes. Diabetes was diagnosed after presenting with DKA at age 22 after he was going through rehabilitation from a motor vehicle accident when he had a spinal cord injury that ended his football career. Current medications include insulin 70/30, 65 units twice a day." That would get my antennas up. I'd go, what in the world? 65 units twice a day? The normal amount of insulin for a type 1, remember, okay, we'll talk about this a little bit later. The average type 1, after they've been type 1 for a while, requires 0.6 to 0.7 units per kilo per day. So this guy's getting 130 units, unless he's just massive. That's a lot of insulin. This person's insulin resistant. Glucose levels have generally been in the mid-200s. Pretty compulsive person, checking the blood sugar an average of 3.1 times a day whenever you look back through his glucometer. And by the way, glucometers can be downloaded to your computer or to their computer. And so there's a lot of technology out there for looking at blood sugar control. Recent implementation of MNT, that stands for Medical Nutrition Therapy. Basically, that's getting educated about diet, following a diet, and following an exercise strategy. And by the way, that will lower your A1C in and of itself somewhere between 1 and 2 percentage points. Okay. This person remarks, though, he says he's been trying to do it, but he says it just doesn't seem to help much, although he's not currently exercising. Past medical history, recovered from his spinal cord injury. Family history, there's a lot of people with vascular disease in his family. Doesn't drink, smokes a pack of cigarettes a day, works as a dispatcher for a trucking firm. Probably not burning a lot of calories, I bet, at that job. Married and has 3 children. Review of systems, nocturia, vision's blurry, feet are always cold. Says he doesn't have any numbness or any pain, no dysthesias in his feet. His exam, height is 70 inches, his waist 44 inches, weight's 245 pounds, he's hypertensive, blood pressure of 162/92. Chest is normal. One interesting thing, the skin tag again, so you all will now know that skin tags are a sign of insulin resistance. And hyperpigmented rash on the nape of the neck, that's acanthosis nigricans, which is also a sign of insulin resistance. Other places you see that on the neck You'll see it in the armpits, and you can also see it in the groin area, the places where people have that. And if you haven't seen that before, I'm sure most of you have it. It just looks like a velvety, hyperpigmented rash. I mean, almost looks like you could just kind of brush it. You know, I mean, it's thicker skin. So, did we have any labs? I didn't see any labs. Oh, yeah, we did before. I'm sorry. Well, we already know this patient's diabetic. So the question is he a type 1 or is he a type 2? Type 1? Type 2? Okay, that was easy.